Thank you, Dr. Rossi. And it's really a pleasure to be here. I want to thank, as always, Dr. Coleman and Dr. Nisvisky for having put up a wonderful, wonderful meeting. We really have had, I would say, a wonderful morning of learning what's happening in myeloma and putting our thoughts. So first, I remind everybody that Jim Berenson and I are good friends. Our main discussion would actually be who should get transplanted or not. But these type of debates actually are a survival mechanism. It's what societies use to prevent going into directions that may actually be detrimental to their long-term survival. These are my disclosures. The most important one is I'm a transplanter, and I actually do believe in maintenance. So think about two cases, and these are actually two cases that come to the clinic. And actually, case number one is a true patient who participated in the CLGBE 104 trial. So she's a 55-year-old female, presented with asymptomatic anemia, and had what would be considered standard risk myeloma with an IgA cap of 3.2. She receives 4 cycles of what was then the induction, bortezomib, thalidomide, dexamethasone, had an autologous transplant, and achieved a complete remission. Think about the same patient, but now as a high-risk patient, and followed by the autologous transplant, she fails to achieve a complete remission and still has a paraprotein peak of 0.4. Think about what you just answered. Would you do no maintenance on patient number 2? Would you do lenalidomide on patient number 1? What data do we have? So we actually have a variety of options, and we have a long-standing history. The first one was, Bart Barloghi did the SWOG trial looking at interferon maintenance, which showed no maintenance, no benefit for interferon maintenance. And we have 3 large randomized trials. The Abdelkafid trial needs to be eliminated because it was retracted, showing that thalidomide post-transplant actually improves progression-free survival and overall survival. Not included in this meta-analysis were 2 negative trials for thalidomide, the one led by Keith Stewart from the National Cancer Center in Canada, and the one done at North America through the BMT-CTN, in which thalidomide maintenance was not only not associated with improvement in progression-free survival, but was shown to be extremely toxic. So based on that, I wouldn't be able to tell you that IMiDs actually are the way to go. But we have 3 trials which I think are very important and should be changing the way we practice. The CLGBE trial was led by Dr. Phil McCarthy and presented in the New England Journal of Medicine and has been recently updated, looks at maintenance lenalidomide versus placebo in patients who underwent an autologous transplant. As you can see, the addition of maintenance lenalidomide doubled the time to progression. And at this time, approximately 30% of the patients remain alive without progression more than 5 years out. Even in the update, even the fact that more than half of the patients who were on the placebo arm went on to get lenalidomide maintenance after the blind was open, there is still a survival benefit that is statistically significant, and the reduction of risk of death approaches 40%. So if you look at what the bar should be today, patients who get len induction, with or without, with bortezomib probably, and get melphalan consolidation and go on len maintenance, their progression-free survival at 5 years is approaching 60%. These are numbers that we have never seen in myeloma today. And the overall survival is more than 80%. The CLGBE trial actually shows the same thing. So if you look at lenalidomide maintenance in the patients who have achieved a major response, so look, case number 1 where you'd say, well, why am I going to do len maintenance? Why are we going to put them on the pill? There's a risk of second malignancies. Why not just leave them alone and watch them carefully? In the CLGBE trial and in the French trial, patients who achieved a major response, either VGPR or CR, still showed a significant benefit for progression-free survival, although no survival benefit as of yet, but this is a curve that's going to take a long time to split. So the other trial that I want to show is the trial that Antonio just reported in ASCO this year. And it looks again in lenalidomide maintenance versus no maintenance in the context of 2 consolidation strategies. So in this trial, patients receive lenalidomide dexamethasone as their induction, and then they're randomized to 2 consolidation strategies. Either one of the strategies is high-dose intense melphalan with autologous transplant, and the other strategy is a continuous consolidation with melphalan orally, prednisone, and lenalidomide. And those groups were randomized to either receive lenalidomide maintenance or no lenalidomide maintenance. So the good news for us transplanters is, thanks to Antonio, we still think that we're going to have a role in upfront therapy for myeloma. Median progression-free survival for high-dose melphalan, 38 months versus 24 months. No survival as of yet, but again, remember, one of the problems with myeloma therapy today is that we might not see differences until 3, 4, or 5 years down the road because of how the natural history of disease has changed with modern treatment. Significant benefit for lenalidomide maintenance. 5-year overall survival, 75% versus 58% for no maintenance. This is not a progression-free survival maintenance. This is a survival maintenance. So Mrs. Smith, it's not that you're going to take this pill every day and your disease is going to take longer to come back, but you're going to live the same amount of time. It's Mrs. Smith, you're going to take this pill every day and your chances of living longer are probably 1 in 5 or more. The benefit is, at 12 months, 24 months, and 36 months for progression-free survival at the landmark analysis. Now, the one thing I will have to maybe concede is that the benefit may not be the same in all risk categories. Now, the caveat here is that I remind you that in this trial, the patients never receive a proteasome inhibitor. And both other trials, both the French and the American, there was a good suggestion that even patients with high-risk disease benefit from maintenance lenalidomide. But in most of those trials, the majority of those patients had received a proteasome inhibitor as part of their induction treatment. And I remind you, as you've just heard, there are more than 4 randomized trials that, when done in meta-analysis, suggest that bortezomib during induction actually makes a difference for long-term outcome. So again, and here looking at case number 1, which for me is the hardest case to decide who should get maintenance, is the patients benefited the most from lenalidomide maintenance. The other, what's the price to pay? So there is a price to pay, and the price to pay is there is hematologic toxicities associated with it, and there's the price to second primary malignancies. But despite the price of second primary malignancies, when they're included in the event-free survival analysis, these patients continue to live longer and live longer without disease. So what I would propose, and I'm hoping that that I will have convinced you, is that 3 trials have shown that post-stem cell transplant therapy with lenalidomide prolonged progression-free survival. One of these trials is actually showing a survival benefit. All trials show tolerability, but we recognize that second primary malignancies is a concern, and a way to identify patients who are high risk of this event is essential, as well to understanding why it happens. Personally, I think it may be happening because we're starting the IMiD too early in the course at the moment that these patients are starting to have a major stem cell expansion. And we remind ourselves that lenalidomide is a thalidomide analog, and there was teratogenicity. The benefit seems to be regardless of response and prior exposure to lenalidomide. It may be that starting it early during the transplant course has a better benefit, but we still haven't identified the sweet spot. And I seriously think that for now, len maintenance should be considered the standard of care. And this is the group at Memorial Sloan Kettering, and we welcome you all to New York. Thank you very much for your attention.